Good afternoon, everyone, and welcome to our webinar, Unlocking Thyroid Health. My name is Tony Brantley, and I'm a program coordinator with the Community Health and Wellness team at Suburban Hospital located in Bethesda, Maryland. We are thrilled to have you with us today for this important discussion. Throughout the presentation, we encourage you to submit any questions for our guest speaker using the Q&A box at the bottom of your screen. At the conclusion of the webinar, a short evaluation will appear. We will greatly appreciate your honest feedback as it helps us improve future programming. Please note that today's webinar will be recorded. The slideshow from this presentation will also be shared with all community members who registered for this program. Again, thank you all for being here. It is now my pleasure and honor to introduce our guest speaker. Dr. Rosalie Naglieri received a BA in biology from State University of New York at Binghamton. She then attended Upstate Medical University in Syracuse, New York, where she received her medical degree. Her residency in internal medicine was served at University of Maryland Medical Center, where she went on to also complete her fellowship in endocrinology, diabetes, and metabolism. She has been published in Diabetes Care and other medical journals. Dr. Naglieri is board certified in endocrinology, diabetes, and metabolism. Her interests include thyroid disease, thyroid cancer, diabetes, obesity, and polycystic ovarian syndrome. She practiced endocrinology in Howard County, Maryland since 2005, and for the last 2 years has been at JHCP in downtown Bethesda location. Without further ado, I'm honored to present Dr. Rosalie Naglieri.
Thank you. So I'm Rosalie Naglieri. I've been an endocrinologist, like Tony said, for the last about 20 years. Thyroid is one of my favorite glands, so I'm excited to talk a little bit about thyroid and how it shapes your health today. So we'll start off with just a brief overview of what we're going to go through today. So we'll start off with what the thyroid gland is and a little bit about it. And then we'll move on to the diseases of the thyroid, which includes hypothyroidism, hyperthyroidism, thyroid nodules or cysts. We'll touch on thyroid cancer. And at the end, we'll touch also a little bit on nutrition and the thyroid. And at the end of the session, we'll open it up for questions and answers so you could get any questions in, and hopefully I could help you with that as well. So let's start off with the thyroid gland and what it is. So the thyroid gland is a small gland. It sits at the base of your neck. It is right underneath the skin and in front of your trachea. It looks like a butterfly. It's part of your endocrine system, and the endocrine system also includes other glands, including the pituitary gland, the pancreas, the adrenal gland, your ovaries and testes, and the thyroid plays a pretty integral role in your endocrine system. It does so by producing a thyroid hormone, or actually it produces two thyroid hormones. One is called thyroxine, which sometimes we refer to as T4, which is the storage form of your thyroid hormone. And then it also produces triiodothyronine, which is also known as T3. And this is the active form of your thyroid hormone, which does all the work for the thyroid. So like I mentioned before, the thyroid can impact lots of your body functions, kind of from like head to toe. So if we start off at the top of your body, the thyroid can impact your brain development. So without thyroid hormone, you will not have normal brain development. So sometimes people are born without a thyroid. And in that case, if that is not discovered at birth, they will not have normal brain development, and they could develop a condition called cretinism. It also can impact your cognition and in your memory. So often patients come in and talk about, they feel like they're losing memory or their focus is off. And that would be something to prompt your provider to check a thyroid hormone level. Mood is also a very common thing that thyroid can impact. It could increase your anxiety. It could cause depression. So many, many years ago, before they really recognized this, sometimes people will actually even have psychosis and end up in psychiatric hospitals. And it was all due to the thyroid being off and something that was very treatable. and also impacts your blood flow to your brain. Moving down to your heart, the thyroid hormone could impact your rate of your heart rhythm. So it can cause your heart rate to go either too fast or too slow. So it does increase your risk if your thyroid is not functioning correctly of conditions like atrial fibrillation or atrial flutter. It also impacts how well your heart is putting out blood into your system. So if the thyroid is either overactive or underactive, it could eventually lead to congestive heart failure. It has some impact on the blood flow to your lungs, and in the liver, it can cause abnormalities in your cholesterol production, leading to increased cholesterol at times. It could contribute to a condition called fatty liver, which is very common in our population, particularly in people who have thyroid disease or other metabolic syndrome related conditions. In severe hypo or hyperthyroidism, it could also lead to liver failure. Moving down to your gastrointestinal tract, thyroid can impact the motility of your gut. So it can contribute to constipation, or it can contribute to loose stools or diarrhea. And by doing so, sometimes that impacts your absorption of certain vitamins and minerals. It also impacts your filtering of your kidney, and it can offset your salt and water balance, leading to electrolyte or not abnormalities, particularly low sodium in the blood. In women of all different ages, thyroid can impact the menstrual cycle. So it can impact the onset of puberty. It can impact menstrual cycles being regular or irregular. It can impact the flow of menstrual cycles. It has impact on fertility, and when the thyroid is off, it can increase your risk of miscarriage. And then other things that also could be contributed to by the thyroid being off will be bone development, as well as bone health maintenance, which includes the risk for osteoporosis. And then a couple other things to mention is it has impact on your blood sugar, as well as your muscle contraction. So knowing now that all these different organ systems can be impacted by your thyroid, then when the thyroid goes off, how does this manifest in symptoms and disease? So we'll move on to the diseases of the thyroid. So we'll start with hypothyroidism. Hypothyroidism is underactive thyroid. It's when the thyroid gland is not producing enough thyroid hormone. So everything kind of slows down, and that's why I have the turtle on the screen. So everything is slowed. So if you think about that, you're more tired, your bowels are slower, and you're more constipated. Your memory, your brain's not thinking clearly, so your memory tends to be off. Your focus tends to be off. A lot of people call that brain fog. It's a very popular term for that. Your mood tends to be slower, and people tend to be more depressed. Skin can be dry, and their hair could be more brittle and eventually lead to some hair loss. Now, not all patients have every symptom of hypothyroidism. There are lots of patients who are walking around with abnormal thyroid function and have no symptoms. In fact, the older you get, the more likely you have less symptoms. And some people have every symptom on the list, and some people have symptoms that are not on the list, because these are what we classically think of as hypothyroid symptoms, but sometimes people present in non-classical ways. And then I forgot to mention weight gain. So typically, the thyroid is very integral in your metabolism. So if you don't have enough thyroid hormone, your weight tends to go up. But occasionally you get the opposite. So sometimes if someone's thyroid hormone levels are off and they're hypothyroid and they're depressed, they stop eating, and sometimes actually the weight could go down. So there's many different causes of hypothyroidism. The most common cause of hypothyroidism is an autoimmune disease called Hashimoto's thyroiditis. So a Japanese gentleman, I think in like the early 1900s, discovered the mechanism by which people become hypothyroid, and Hashimoto's thyroiditis is basically your body sees itself as foreign, and so the thyroid is identified as not supposed to be there in your body. And what happens is that the body sends all these lymphocytes, which are white blood cells, into the thyroid gland itself. This causes inflammation. That inflammation over time causes damage and eventually scarring, and then the thyroid stops working normally. Sometimes this damage is complete and the entire thyroid stops working, and sometimes it's partial and you only get mild hypothyroidism. Other causes of hypothyroidism include the pituitary being damaged. So the pituitary is kind of like the master gland in the endocrine system. And so it kind of controls everything below it, including the thyroid. So if your pituitary doesn't work, then your thyroid also doesn't work. Obviously, if you had your thyroid removed in a surgical procedure for whichever reason, that would cause you not to be able to produce thyroid hormone and needs to be treated. There's some common medicines that are out there that can cause hypothyroidism. So lithium that has been used in the mental health field is known to cause hypothyroidism. There are drugs in cardiology, such as amiodarone, which is used for atrial fibrillation or flutter, that can cause hypothyroidism. And then a lot of the new oncology drugs, which are what we call targeted chemotherapy, they cause both hypothyroidism and hyperthyroidism, as well as other endocrine disorders. And then lastly, if there's not enough iodine in your diet, that can lead to hypothyroidism as well. In the US, most of us have enough iodine, but there are certain circumstances where that still could be seen. So how do we diagnose hypothyroidism? So there are pretty much 4 basic tests that would help you diagnose hypothyroidism. So the most commonly used test is TSH. Okay, TSH stands for thyroid stimulating hormone. It is a hormone that is actually produced by the pituitary, not by the thyroid. And so if you look on the screen, we have this like pink gland here, okay? And then below it is the thyroid. So the pink gland is your pituitary gland. It makes lots of hormones, one of which is TSH, which is thyroid stimulating hormone. And thyroid stimulating hormone stimulates the thyroid to produce thyroid hormone, which is the T4 and T3 I mentioned earlier. And these are the hormones that do the work of the thyroid. So when there's not enough T3 and T4 in your bloodstream, then that sends a message back to your pituitary gland that there's not enough. So the pituitary gland is then going to produce more TSH, which is then going to try to stimulate your thyroid to make more thyroid hormone. But when the thyroid can't do that, then the pituitary will continue to send out more and more TSH to try to get more thyroid hormone to be produced, and that TSH will rise. So when you're hypothyroid, you have a high TSH. And then the free T4 or the T4 level can be checked, and that is the actual thyroid hormone that's floating around in your blood, and that's what we use for the action of the hormone. And that T4 level, I think I mentioned earlier, is the storage form, and then it gets converted to T3 in your organs and your muscles, and then that causes the work of the thyroid to be done. And the last test that we check, if we're thinking that the patient's cause of hypothyroidism may be from an autoimmune disease, is something called thyroid antibodies. There are 2 of them that we typically check in hypothyroidism. One is called thyroid peroxidase antibodies, or TPO antibodies, and the other one is called thyroid globulin antibodies. And these are markers that the immune system is off, and it is creating a level of antibodies to attack the thyroid. And that's a marker in the blood that would confirm if you had autoimmune thyroid disease. All right, so this is just another representation of what I was just saying. So this is your pituitary gland, this is your thyroid down below. And if the level of thyroid hormone, the T4 level, is low, it feeds back to the pituitary gland, and the pituitary gland says, oh, we need more, and tries to stimulate your thyroid to make more. But if the thyroid's not working, that doesn't work, and that TSH will go high, and the T4 will be low. Now, I will tell you that this is counterintuitive, right? So when you say hypo, you think low, but in hypo, the TSH is high. And so people get that confused. Once you understand this feedback network, it gets a little bit easier to understand. And so how do we treat hypothyroidism? Well, many years ago, before we knew what the thyroid's role was, people's thyroids would either be cut out because they had large thyroids, or their thyroid stopped working. And if people didn't have thyroid hormone replacement therapy, they would eventually go into a coma and pass away. So thankfully, someone came up with the idea that we should replace the thyroid hormone. And initially, when they first thought of this idea, they would actually give patients actual animal thyroids to eat. So back in the day, they used to have patients eat like 2 half sheep thyroids a week to supplement the thyroid hormone. But since then, science came along and we have synthetic thyroid hormone or levothyroxine, which comes in a pill. It's a 1 pill a day regimen. It's a small pill. Levothyroxine comes in many brands. The most popular brand is probably Synthroid, but there's other brands like Levoxyl and Tyrosint. The dosing usually is weight-based, but that will vary because sometimes people need full replacement and sometimes you just need a supplemental dose. Occasionally, levothyroxine by itself, which is synthetic thyroid hormone, is not enough for certain patients to feel good. So occasionally we'll do combination therapy of levothyroxine plus liothyronine, which is T4 plus T3. Prior to synthetic thyroid hormone, what we used universally was pig thyroid hormone extract, also known as Armour thyroid. Armour thyroid still exists. People still take Armour thyroid as of 2026. I prescribe some people Armour thyroid because that's what they feel best on. And so some patients struggle with hypothyroidism symptoms, even on thyroid hormone. So we do try to help with that those lingering symptoms. Majority of people who gets put on thyroid hormone are on thyroid hormone for life. So when hypothyroidism happens, it usually doesn't go away except for in cases of thyroiditis. And so this is usually a lifelong medication. The dose of the medication can change over time. This fluctuates with weight changes. So if you gain a lot of weight, your dose may go up. If you lose a lot of weight, your dose may go down. Hormonal changes will change the requirements for thyroid hormone, such as pregnancy. Thyroid hormone requirements go up because estrogen levels go up. So whenever estrogen levels go up, thyroid hormone needs to go up. And then if you deliver the baby, the thyroid hormone level will go back down. If you start hormone replacement therapy in menopause, your thyroid hormone needs will usually go up. There are other medications out there that can affect the absorption of thyroid hormone, such as acid reflux medications. Other medications like lithium and amiodarone that I mentioned earlier can also impact your thyroid hormone needs. So whenever a doctor or provider puts you on a new medication, if you're taking thyroid hormone, it's usually a good idea to ask if you need to take it separate from your thyroid hormone and the timing between the two, and if there's any potential impact so that your levels don't go out of whack. So the opposite of hypothyroidism or underactive thyroid is hyperthyroidism. So the symptoms are going to be all kind of fast forward symptoms. Everything's going to be faster than you expect. So you'll be hotter than usual. You won't be able to sleep and you have insomnia. Instead of depression, you're more likely to have anxiety. Your metabolism gets sped up. So you'll have unintentional weight loss. In severe cases, like I've had people eating like 7,000 calories a day and still just maintaining their weight in certain cases of hyperthyroidism. Loose stools can happen or diarrhea, and then heart palpitations because of that impact of thyroid hormone on the heart makes it beat faster. And so sometimes, if you present to the emergency room with atrial fibrillation, your heart rate is fast. One of the tests they'll be ordering in the ER, or they should be ordering in the ER, is a TSH level to make sure that you're not hyperthyroid. So there's several causes of hyperthyroidism as well. The most common cause of hyperthyroidism is an autoimmune disease, just like hypothyroidism, except it's kind of the opposite of Hashimoto's. We call it Graves' disease. So a gentleman named Robert Graves many years ago came up with the mechanism and he got his name tagged onto the disease. It often can be genetic as well as Hashimoto's. I forgot to mention that. And in this case, the autoimmunity is slightly different. So in this case, the body produces a protein or antibody that attacks the thyroid and stimulates the thyroid abnormally. And this causes the thyroid to overproduce T4 and T3, and that causes the symptoms that we just mentioned. Graves' disease sometimes is associated with thyroid eye disease. So if you see the picture here on the left, this woman has kind of like bugged out eyes, and you can see the swelling around the eyes a little bit. That's caused by this autoimmune process causing the eye muscles that control your eye movement to become swollen. And that causes a protrusion of the eyes. Sometimes the eye will get stuck. Not all patients with Graves' disease get thyroid eye disease, probably about 12 to 20% or so. Thyroid eye disease can be a very challenging complication of Graves' disease. There are some newer medications over the last 10 years that have helped that, but it still can be somewhat challenging to deal with. Another cause of hyperthyroidism could be nodules or growths in the thyroid that are overproducing thyroid hormone. So here in the picture here, you see this big black circle. That is a growth in the thyroid that is overproducing thyroid hormone. And sometimes it's one nodule, which we call a hot nodule. And sometimes it's multiple nodules producing extra thyroid hormone. And then a couple other causes of hyperthyroidism is thyroiditis. So what happens in thyroiditis, which is usually triggered by either hormonal changes like postpartum or by viral infections or trauma to the thyroid, what happens is the thyroid becomes inflamed and releases all its thyroid hormone into the bloodstream. So you become hyperthyroid and you get symptoms of hyperthyroidism. And then after a month or two, then the thyroid tends to start healing. And then you go into what we call a hypothyroid phase of thyroiditis, and then eventually it goes back to normal. And that happens over somewhere between like a 2 to 6 month interval. So usually in those cases, we treat patients' symptoms and that fixes itself. And then there are some medications that I already mentioned that also can cause hyperthyroidism. So back to that same screen we had before. So hyperthyroidism will be the opposite. The TSH will be low because that thyroid stimulating hormone, that TSH that's coming from your pituitary, is sensing that there's way too much thyroid hormone floating around in your blood. So then the pituitary gets the message, we don't need to stimulate the thyroid to produce any more thyroid hormone. So we're going to lower that TSH level. So your TSH level will be low and your T4 level will be high in hyperthyroidism. So how do we treat hyperthyroidism? Well, one of the things we do is we use beta blockers. You know, what beta blockers are they're very commonly used for heart rate regulation or blood pressure. And so in hyperthyroidism, because the heart is seeing that extra thyroid hormone, we want to slow the heart rate down, and we'll use beta blockers to slow that down. And that helps protect you from going into abnormal thyroid rhythms or into heart failure. The beta blockers also sometimes will contribute to decreasing the conversion of the storage form of thyroid hormone to the active form. So it has two roles in using them in treating hyperthyroidism. And then we also use what we call anti-thyroid drugs. There are two anti-thyroid drugs. One is methimazole, and the other one is PTU. We use methimazole more than PTU because PTU tends to have a higher risk of liver side effects. These two drugs have been around for longer than I've been a doctor, and nothing really has changed in terms of advancement in hyperthyroidism treatment. These are the two main drugs we use. And the way these drugs work is they decrease the ability of the thyroid cells to make more thyroid hormone, and they also decrease the release of thyroid hormone from the gland itself. A couple other measures that we could use to treat hyperthyroidism one is called radioactive iodine. Why we would use radioactive iodine is because thyroid hormone itself, that chemical structure of thyroid hormone, the molecule has several iodine moieties on the molecule itself. So when you take radioactive iodine, which usually is taken by a pill or a liquid, it incorporates that radioactive iodine into the thyroid hormone within the gland, and then that will destroy the gland and stop it from working. Those patients will eventually become hypothyroid and end up on thyroid hormone. The reason why you would choose to do that varies. So sometimes people cannot tolerate the oral pills. And so when they are not tolerating or if they have side effects, we sometimes move to radioactive iodine. And then, some people choose that they don't want to be on a pill, like methimazole or PTU for either worry of side effects or just that's their preference. And so they will choose to do radioactive iodine. And then Sometimes we will then move on to surgery and have the thyroid gland removed. And that also would lead to that patient being hypothyroid and needing thyroid hormone. Some patients, when they are treated for hyperthyroidism, do go into remission. So usually we tell patients that, if we treat your hyperthyroidism for 18 months, and this is specifically to Graves' disease, then it's possible that they could go into remission and come off medication and not need any medication at all. So now moving on to thyroid nodules and cysts. So thyroid nodules are growths in the thyroid. They're usually solid growths. And then there's thyroid cysts, which are usually fluid-filled growths in the thyroid. So the picture kind of shows you this woman's neck, and this little bump here would be a thyroid nodule or a cyst. They typically will be detected either by you going to your physical exam or doctor's appointment, and your doctor feels your neck. It's actually good for your doctor to check your neck. So if your doctor doesn't check your neck, you should ask for it. Most patients who have thyroid nodules do not have any symptoms. They just grows over time, and then someone notices, either the doctor notices it or the patient notices a lump on their neck when they stretch their neck out, when they're taking a shower or something. Or sometimes thyroid nodules are noticed on imaging. So a lot of times patients will go to the emergency room for another reason. They'll do a CAT scan of the chest, and that kind of captures part of the neck, and a thyroid nodule will be seen on the imaging, and that will lead to a further evaluation. Another common imaging test that will find thyroid nodules is a carotid ultrasound, where they're looking at the arteries in your neck, and the thyroid sits right next to the arteries. And sometimes you'll pick nodules up on those exams as well. Often patients ask, well, why do I have a thyroid nodule? And often we can't tell them exactly why. Patients who have hypothyroidism or hyperthyroidism are at higher risk of having thyroid nodules or cysts, but most often thyroid nodules or cysts are found in patients who have normal thyroid function, and the thyroid is still functioning normally. Thyroid nodules and thyroid cysts usually do not cause thyroid dysfunction, except for occasionally they'll make extra thyroid hormone, like I mentioned earlier. Thyroid nodules are super common. Talk to enough people, you'll find out that one of them probably has a thyroid nodule, and by the time you're in your mid-60s, probably close to half of people have a thyroid nodule or cyst, be it clinically evident or not. Majority of these nodules and cysts in the thyroid are going to be benign, over 90% of them. So when someone gets a thyroid nodule or a cyst, then we have to then take a next step and just start evaluating it. So the first step in evaluating these is something called a thyroid ultrasound. We're looking for what these nodules look like. Is it a cyst? Is it a solid growth? And what features that cyst or solid growth may have. So below you see is a picture of an ultrasound, and here where I'm circling with my cursor, if you can see it, is this black circle here is your thyroid nodule. And when we look at thyroid nodules on ultrasound, we are looking to see what that nodule looks like. And there's certain features that we're looking for. We're looking for how big the thyroid nodule is. Is it greater than a centimeter or less than a centimeter? Is it 4 centimeters? We're looking at the shape. Is it wider than tall? Is it, what do the borders look like? Are the borders nice and smooth? Or the borders irregular and ragged? What the color of that nodule is compared to the rest of the gland. So you can see this nodule is dark and looks black, and then next to it is what we would call normal thyroid tissue, which is this kind of whitish gray color. So this is something we would call a hypoechoic nodule, which is darker than the rest of the gland. When a nodule is darker than the rest of the gland, it tends to have a higher risk of not being benign. Most of these are still benign, but it would have a higher risk than if the nodule was the same color or brighter than the rest of the gland. And then we also look for calcifications. If a nodule has calcifications, it does put it at a higher risk of being worrisome nodule. This just on the right here, just so you know, is just looking at the blood flow. So, typically nodules that have more blood flow would be more worrisome, but this doesn't always pan out. And just to point out, this brighter spot here is your carotid artery. So that's how close the thyroid is to your carotid artery. So once we get the ultrasound and we decide if this nodule looks benign or it looks worrisome, and what size is it will determine if we're going to do any further evaluation or we're going to just monitor this nodule. So when you get an ultrasound report of your thyroid, it's going to actually score your nodule, 1 being not worrisome and 5 being very worrisome. And so that sometimes determines if that nodule gets further evaluation or we continue to monitor it with imaging. So if we had a nodule that needed further evaluation, the next step would be something called a thyroid fine needle aspiration. Some people call it a thyroid biopsy, but it's actually more an aspiration because we don't actually take a chunk of cells out. We take a sample of the cells with a very thin needle. This is usually done under ultrasound guidance, so we know we're getting into that nodule. Many years ago, prior to that, prior to me being an endocrinologist, they used to just palpate the nodule and stick the needle in, but we've learned that it's better if you see where you're going. This procedure is usually done by either a radiologist or endocrinologist, occasionally done by surgeons as well. Usually there's local anesthesia and the patient is awake and you are laying on a table with your neck extended backwards to bring the thyroid closer up to the surface. And then the needle is inserted through the skin into the thyroid. Typically, you're going to get somewhere between 3 to 4 passes of the needle to get enough sample of what's in the thyroid. And then that sample is sent off to a pathologist and they look under a microscope to induce special stains to see if those cells that are in that nodule are benign or do they look concerning. So depending on what comes to that biopsy, some patients end up in thyroid surgery. Other patients, if the results come back benign, those patients will be continued to be monitored with ultrasound over time, typically on an annual basis, but that varies. If the nodule comes back and the results are suspicious, those patients are usually sent to surgery. There is a category that comes back on those biopsies that are indeterminate, and some of those patients we monitor and some of those patients we send to surgery. There is a special test, which is a test that looks at genetic mutations in the pathology, and that sometimes determines where that patient goes. Typically, when you go to thyroid surgery, you want to go to a thyroid surgeon or an endocrine surgeon or an ENT who does these surgeries all the time because there are very specific risks to thyroid surgery. One of them is your vocal cord nerves. The vocal cord nerves sit right behind your thyroid gland. There's superior and inferior nerves that are sitting back there. And if those nerves get cut, then that will impact your voice. If all the nerves get cut, then you end up with a tracheostomy. So you absolutely should see a experienced endocrine surgeon. Most ENTs, most general surgeons get taught how to do thyroid surgery, but they don't do it all the time. And if you have access to someone who does them all the time, you should use that surgeon. The other thing that is at risk for during thyroid surgery that's specific to thyroid surgery is the parathyroid glands. So they are also part of your endocrine system. They regulate your calcium metabolism. They're very small, kind of pea-sized shaped glands. They're often adjacent to the thyroid or sometimes stuck to the thyroid via tissue. And they are sometimes hard to identify because they look like little fat globules. And so you really need that experienced surgeon to be able to identify them so you don't lose those glands during the surgery. Because if you lose those glands during the surgery, you will be on lifetime, not only thyroid hormone, but you will be on lifetime activated vitamin D and calcium tablets. And that is not a desired complication of this kind of surgery. And then there's usually the other risks are typical for most surgeries, like infection and bleeding, what have you. The scar on the screen is probably a little bit bigger than we see these days. They tend to be a little bit smaller. There are other ways to do thyroid surgery other than going through the front of the neck. There are some patients who've had thyroid removal through the lower inner lip. But typically the standard is through the base of the neck. And the surgeon is going to try to find a line in your neck so that eventually that scar will blend into your necklines and you won't be as obvious. The reasons why people will get sent to thyroid surgery other than suspicious for a nodule that was suspicious for thyroid cancer would be if the nodule continues to grow over time or it starts causing what we call compressive symptoms, which would be trouble swallowing because the nodule is pressing on the esophagus, or trouble breathing because the nodule is starting to put pressure on your windpipe. And for some people, their nodules grow very much outward. And when that happens, cosmetically, that's not desirable. And sometimes that will be a reason to go to surgery. Now, nowadays, in the last probably close to a decade, we have been doing things other than surgery for thyroid nodules. This is for benign thyroid nodules. Thyroid cancer, we still usually mostly are doing surgery at this point. But there is a procedure that is now being better covered by insurance for thyroid nodules to shrink them. So if you have a nodule that's growing that has been biopsied benign, then you may be a candidate to do something called radio frequency ablation, where they stick a needle into the thyroid nodule and they shrink it. And it doesn't go away completely. Often it gets to about 50% in size, but often this will allow for that patient not to have to go through a major procedure like surgery. You avoid getting a scar, and then you also preserve the thyroid function, and so you don't necessarily have to take a pill. And a couple other things we'll do with thyroid nodules. So like I mentioned before, benign thyroid nodules, on appearance, we'll watch them. If a nodule is biopsied and benign, we'll continue to watch them, usually annually for at least 5 years, and then eventually we'll spread that out or stop watching them over time. If you have a cyst, which is just a simple cyst, so it's just a nodule that is filled with fluid, and that's what this dark space here is, all fluid, then there is a procedure you could do to shrink those cysts. And basically that is putting a needle in there and injecting ethanol, and that will shrink the cysts, and that also avoids that patient from having to go to surgery, which is a nice thing. And if you have those nodules that are overproducing thyroid hormone, you can do radioactive iodine to treat those. So just to touch a little bit about thyroid cancer. So about 10% of those nodules are going to be thyroid cancer. There are 4 types of thyroid cancer. The most common types are going to be papillary and follicular thyroid cancer. They are typically non-aggressive tumors, and are usually very treatable and cured with surgery. However, there are probably about 5% of those cases are not going to be non-aggressive and are a little bit more complicated. There are a few other types of thyroid cancer. Medullary thyroid cancer is less common, tends to be familial, and that's primarily a surgical treatment. And then there's anaplastic thyroid cancer, which is much more rare, however, is much more aggressive, and those patients often have a difficult course. I would say in 20 years of practice of my own patients, I've probably only seen maybe 3 or 4 anaplastic thyroid cancer cases, where I've seen papillary and follicular hundreds and hundreds and hundreds of times. Approximately about 40,000 new cases of thyroid cancer are diagnosed each year. About 2,000 patients die of thyroid cancer a year, and this is in the United States, and probably just about 900,000 are living with thyroid cancer as of about 4 or 5 years ago. And now to move on a little bit about nutrition and thyroid. So I would say that this is one of the most popular questions I get when patients come in and they have thyroid dysfunction or something going on in their thyroid. Like, what can I do to change my thyroid health? There's honestly not a ton of research and that is out there, but it's improving over time. A very popular question people ask is if they need to stop eating cruciferous vegetables, and the answer is no, you do not need to stop eating cruciferous vegetables, but you want to diversify your vegetables so that you don't get exposure to just one type of vegetable. And I'll get a little bit more into that in the next slide. So just to talk about what's important in your diet for your thyroid health. So iodine, as I mentioned earlier, is a part of your thyroid hormone molecule. So you definitely need to have enough iodine in your diet. If you have not enough iodine in your diet or too much iodine in your diet, they both can cause consequence in terms of thyroid function. So, back many years ago, there was in the Midwest of the United States, there was something called the goiter belt, where people had these huge thyroids, and those goiters were attributed to low iodine in our diet. So that's why you have iodized salt. And a lot of our products have iodine in it. In fact, probably one of the most common sources of iodine in the United States is dairy products. And so most of us are not going to be iodine deficient in this country, except if you're dairy free or if you are vegan, and you will be at a higher risk of having iodine deficiency. And so because there is a limit to how much iodine you should be taking in, you should not, in my opinion, buy iodine drops. Okay, there is about your maximum iodine intake should be about 150 micrograms of iodine in a day. And so if you're going to take a supplement, you should make sure that you actually know how much you're taking in. And then one other comment about iodine is that there's a big movement to pink salts, okay? And everyone's buying pink salt, and a lot of times that is not iodized. So you make sure that you're getting some source of iodine in your diet. Selenium is something that I recommend to a lot of my patients. So if a patient comes in and they have early Hashimoto's or they have thyroid disease, selenium has been shown to help that autoimmunity and support the immune system. And so I often recommend people actually eat 1 to 2 Brazil nuts a day, because that's going to give you all the selenium you need in your diet. If you're nut allergic or you don't like Brazil nuts, you could buy a selenium supplement, and typically it's about 200 micrograms a day. This helps protect your cells from your thyroid cells from having damage, and that allows for normal thyroid hormone production, and this leads towards the autoimmunity. This was first noted in thyroid eye disease. So that thyroid eye disease I mentioned before seems to improve when you give patients selenium, and then since then it's also been studied in Hashimoto's. Having normal iron levels also is important for thyroid hormone production. So technically, if you're iron deficient, that could put you at higher risk of hypothyroidism. And then vitamin D, which is probably one of the most popular vitamins that people take today, is we have receptors for vitamin D pretty much everywhere in our body. And one of those places is the thyroid gland. And it seems to be that maintaining normal vitamin D levels seems to help with decreased risk of the autoimmune thyroid disease risk. A couple other things in your nutrition that are important is zinc. Most of us are probably getting zinc in our diet, but not always. And I think the only times I've ever seen people have zinc deficiency would be in patients who've had conditions like gastric bypass and they have malabsorption issues. So I've seen that happen over time. I've also seen that in patients who have restrictive diets. So in vegan diets, sometimes I found zinc deficiency. So any kind of restrictive diet, you start losing certain minerals and elements. So, make sure if you do follow a vegan or a vegetarian diet, or if you follow other restrictive diets, just being dairy free for what have you, you're paying attention to what you're losing so that you supplement that back, so that not only your thyroid, but other activities in your body are still going to be able to work correctly. Magnesium also is impactful. Copper, vitamin B12 has been associated with impacting the ability to produce normal thyroid hormone, and then vitamin A. And again, vitamin A is not something we're typically going to be low in unless you have some sort of restrictive diet or some sort of malabsorption issue. And then lastly, just to go over, so, a very hot topic in medicine is the gut bacteria or gut microbiome. And, your gut is very important in the role of metabolism and your energy and your immunity. So anything you put into your gut is going to impact not only your endocrine system, but your risk of other diseases as well. So it's very important that you eat a diversified, healthy diet so that you keep your hormones in your gut healthy. And there are things that will disrupt your gut microbiome, and those are things that you're going to be exposed to in your diet, pesticides on your food, things in your environment like cleaning supplies, and then things in the water system. And so, being mindful of washing your vegetables really well and limit your exposure as best you can. And now I think we're good to get on to our question and answers. So I will let Tony take over.
Thank you, Dr. Naglieri, for that very informative presentation. We will now move to the Q&A portion of the webinar. Dr. Naglieri, it's not a question, but actually a comment that I think the audience would love to get your perspective on. It comes from Deborah. Deborah says, I'm particularly interested in nodules. I'm monitoring something. Want to avoid surgery. No cancer determined right now. Watching info about RFA and other non-surgical approaches.
So you could do RFA. So depending on your size of your nodule, if someone RFA is a potential option. Not all surgeons do RFA at this point. Not all nodules are candidates because sometimes, depending where that nodule is located, could sometimes be too risky for that procedure. But there are plenty of surgeons. There's a couple here in Bethesda that do RFA. I'm pretty sure Georgetown and GW have some physicians downtown Baltimore. So we have plenty of physicians in the area who do RFA. Howard County has a physician who does RFA as well. So, it is an option. If that nodule has been biopsied benign, then that is a potential option for you. And it is now better covered by insurance, where a couple of years ago it wasn't. So that definitely could be an option. So I would recommend, if you need to have a procedure done, or you're considering that procedure, that you pick a surgeon who does both surgery and the RFA, so that you could have a discussion which one they think is a better option for you. Here in Bethesda, we have a Dr. Dillon who does both. She's amazing. So yeah, you should consider that as an option, because that may avoid you having to get surgery, which, like we mentioned, the risk for, as well as it may help avoid you having to take thyroid hormone, which is often a bonus for people. Hopefully that answered that.
Thank you. Our first question, in case of hypothyroidism, even after maintaining hormone levels by taking levothyroxine, why are LDL levels still high?
So that may not all be related to just thyroid alone. Okay. So thyroid can contribute to that. But there's a lot of reasons why people's LDL cholesterols can be high. Most often it could be genetic, because cholesterol is very much a genetic thing. So it may not all be thyroid hormone that's making that LDL be high, is what I would say.
Our next question comes from Mega. What is the plan if antibody is high but hormone levels are normal?
Right. So in that circumstance, it depends on where that normal, that TSH is in the range, and if that patient is symptomatic or not. So if the patient's TSH is in the higher part of the range and they're having symptoms, sometimes we treat that with thyroid hormone. But for the thyroid antibodies, a lot of that, I'm going to talk to patients about the selenium. I have seen selenium supplementation, or the Brazil nuts, actually help those thyroid antibodies come down. And then vitamin D and B12 seem to be helpful in those circumstances as well. And then other stuff is going to be lifestyle stuff, trying to make sure you get proper sleep, and you're exercising, and things that are going to help support your immune system, because those antibodies, remember, are a marker of your immune system. So when your body is under stress, then your immune system responds, and that will keep those levels up. But those supplements that I mentioned, and some of those things are going to be things that sometimes help. Selenium, I would say, is probably the thing that I've seen most powerful.
Dr. Naglieri, in your experience, what have you seen as far as the role of heredity in women's thyroid disease? Pam would like to know, what is the role? And she also mentions that she had a large goiter removed, as did her grandmother, although she did not survive the surgery.
So I would say that it's very much genetic. I take care of numerous family members who have thyroid: moms, daughters, sons, brothers and sisters. Thyroid is, particularly the autoimmunity, is very genetic, but so are thyroid nodules. There's a lot of families that have thyroid nodules. So there is a huge genetic component to thyroid disease. And I probably, with your grandmother, I don't know how old you are, but thyroid surgery, years ago versus thyroid surgery now, is very different, but I will tell you, like, that's why I tell you to go to an experienced thyroid surgeon when you have your thyroid removed, because you're going to just get a much better outcome in many ways.
Thank you. Our next question comes from Jane. She has a question on basing levothyroxine dose on TSH levels. Also, types of adjustments for age 70 or older.
Right. So in terms of where that TSH should be based on age, so the TSH naturally will rise with age. So when you get to about 75, that TSH level tends to rise in many patients to the higher part of the range. And that's thought to be heart protective. Okay. So usually in patients who are 75 and older, we do not tightly control the TSH and put it into the lower levels. However, okay, that also sometimes is depending on the patient, because if that patient feels horrible with a TSH of 4 and they feel better at a TSH at 2, then we may tweak it so that they feel good, right? Because it's a balance between what guidelines say to do and what that patient is experiencing, right? So, TSH, so where that TSH is going to be, it's going to be very patient dependent. And yes, age is a factor. Other factors are, what your goals are. So someone who has a history of thyroid cancer, we tend to keep the TSH on the lower part of the range. Someone who's pregnant, we keep that TSH under 2.5. So there's a lot of different nuances. And then some people, you put on thyroid hormone and they feel horrible if you put their TSH, from 5 to 2.5. And so some people who are mildly hypothyroid, we just watch and we don't treat that, because not everyone needs to have a perfect number if it's not causing consequence. If that TSH goes above 10, then we usually put those patients on thyroid hormone, because we know that that could be more consequential to them. To answer, I think, what was the other part of the question? Because I missed, I think I answered one part, but not the other. What was the first part of that question?
I'm sorry, let me follow the question again. I'll be doing some
It's okay.
additional questions.
So, it was the TSH, I remember. So,
yes. Correct.
so it is debatable if a TSH alone is what we should be using. I would say, in terms of cost effectiveness, when you order thyroid labs, just doing a TSH as a screen is usually what's recommended. However, you sometimes miss things if you only do a TSH, right? And so often most patients are getting a TSH and a free T4, and that kind of gives you a bigger picture. If we're concerned about patients not being able to convert from T4 to T3, which is a thing, sometimes we'll also add the T3 to the panel. Not all doctors will do that automatically. Sometimes you need to ask for that. I don't think they're exorbitantly expensive tests. So by asking for that, I don't think you're wasting healthcare dollars, right? But if you're not feeling well, examining the other parameters makes sense.
Do you recommend that thyroid nodule ultrasound be done every year?
So it depends on the nodule, right? So if you have a small, benign looking nodule, that ultrasound probably does not need to be done every single year. And it also depends on, we talked a little bit about the score, right? If it's a kind of intermediate score and it's not necessarily benign 100%, but not worrisome looking, sometimes we'll follow those every year for about 5 years. There's new guidelines that came out in the past year that say that if you follow a nodule for 5 years and it's benign appearing or has been biopsied benign, that you don't necessarily have to follow that ultrasound at all anymore. And I think that is, again, it's a guideline. So guidelines shouldn't dictate what doctors do. They should guide what doctors do. So if you have a really young person, you don't necessarily want to forget about that thyroid nodule. But if you have someone who's 85 and you've been following for 5 years and it hasn't grown, the odds of that nodule causing any consequence in their lifetime is pretty slim. So at that point, we may cut the imaging down or space out the imaging instead of every year, do it every few years.
Our next question is actually a statement and a question. I read somewhere that hypothyroidism can impact breast milk production for new moms, even if the mom is taking her prescribed medication. Is there anything that a patient can do to help with this symptom?
So I would say that typically if you are hypothyroid, and it's treated, it shouldn't have dramatic impact on your milk production, but beyond, other than all the things the lactation consultant tells you to do, like, the supplements and stuff like that, there's no other specific thing that we know about that would help that. It's a good
What
question.
causes Hashimoto's, and are there any studies on whether it is higher in certain regions? Correlation with PFAS in water. Can it ever decrease or go away?
So what causes Hashimoto's are probably multiple things, right? So I mentioned, things in our environment. So there's a lot of endocrine disruptors out there that can cause the thyroid to kind of go into that autoimmune, the body to go into that autoimmune process. We've seen viruses. So in the world of COVID and the pandemic, COVID definitely increased the level of autoimmune thyroid disease. We've seen dietary factors. So, for years, just autoimmune disease in general has been linked to diet. And that's where, making sure that your diet's balanced and you're getting all the nutrients you need is very important, because that can cause that to cause Hashimoto's. There are, I would say, in terms of regions of the world, I mean, there's definitely, you're going to have more thyroid disease in places where you're going to have more health disparities, right? So like in patients who, in places where they don't have adequate nutrition, they're going to more likely have thyroid disease. Even in the United States, if you have people who have better access to healthier foods, they're going to have less autoimmune thyroid disease than people who don't have that access. So I would say that there's probably multiple reasons why people get Hashimoto's. I will tell you that Hashimoto's, autoimmune disease in general, but Hashimoto's sometimes you'll notice it's there and it starts and then it stops, right? And so not all patients who have Hashimoto's end up hypothyroid, right? And so there are acute autoimmune destruction of the thyroid, and then there's these lingering Hashimoto's, and sometimes by moving away from the insult that caused the autoimmunity to start, or changing nutrition, or improving your lifestyle, you have the ability to sometimes stop that process if it's early on. Once it's done and the thyroid is completely destroyed, you're not going to be able to reverse it at this time. Doesn't mean that you shouldn't do other things to support your immune system, because you don't want more autoimmune diseases, because once you have one autoimmune disease, you're going to be at higher risk for other ones, right? So you still should do all these things, but it just depends on where you are on that spectrum. In early Hashimoto's, you have some power. On the full destruction, you probably don't have much power to make change.
Thank you, Dr. Naglieri. Unfortunately, we are getting close to time, so we will take 2 questions. The next one I have is Ava. I have hypothyroidism, taking levothyroxine. However, the level of my TSH goes up or down every 6 months, and my doctor increases or decreases the medication. Why is my TSH not stable?
So there could be several factors to that. Sometimes when people take generic thyroid hormone, they're not always getting the same generic. So sometimes in those cases, we recommend people do branded thyroid hormone if they could afford it, because that keeps the levels more consistent. Sometimes it has to do with how the patient is taking the thyroid hormone, so making sure that that thyroid hormone is taken on an empty stomach, separate from food by at least a half hour, calcium-containing products at least an hour, and all vitamins and supplements for the most part should be 4 hours separate. Other medicines that are sometimes typical culprits are going to be acid reflux medicine. So that could be a problem. Occasionally that patient is having like abnormal absorption issues. And so occasionally if I have people who have really wacky thyroid absorption, it's all over the place, I'll screen them for another autoimmune disease called celiac disease. So there's a lot of different reasons. I don't know if I could specifically tell you your reason, but if that's happening all the time, then sometimes there are things to kind of fix or fine tune that can alleviate that problem.
Thank you. And our last question, if there is vocal cord damage following surgery, will it be permanent or can it heal to some degree?
So it depends on the extent of the vocal cord damage. So if that vocal cord is just, irritated and a little swollen post-surgery, that often will improve and usually improves within the first few months post-surgery. If there is some damage there but not permanent, that surgeon often could send you to a speech therapist and they could work on improving that. So there is improvement. If the vocal cord nerve is completely cut, that is not likely to come back. Okay.
Ladies and gentlemen, this concludes today's webinar. On behalf of the Community Health and Wellness team at Suburban Hospital, we sincerely thank you for joining us and extend our deepest gratitude to Dr. Naglieri for sharing her expertise today. We hope this discussion helps you make more informed choices regarding your health. As a reminder, please take a few moments to complete the survey that will appear at the end of the webinar. Your feedback is greatly appreciated and helps us improve future programs. Thank you again and have a wonderful rest of your afternoon.
Okay, thank you so much. Thanks for
Thank you,
taking
Dr.
this.
Naglieri. Thank you.
Bye-bye.